Hi, everybody, and welcome to the Lown Medical Group webinar series. It is our great pleasure to invite experts from around our medical community to join us to educate us about things that help improve our health and longevity. My name is Dara Lee Lewis. I'm the medical director at the Lown Group, and today I am so excited to introduce two world experts on infectious disease. One of them is our own Dr. Joel Katz, one of our primary care physicians here at the Lown Medical Group. He's also Senior Vice President for Education at Dana-Farber, but today the hat he's wearing is as an infectious disease specialist. And we're joined as well by Dr. Lindsay Baden, who's the Director of Infectious Disease at Dana-Farber. So Joel, I will let you start. And meanwhile, I want to welcome the audience. I see lots of familiar faces in the audience and lots of new faces as well. So this is free and open to the public. We invite you to share this with your friends and colleagues, and we'll post the webinar on our website by the end of next week. As our speakers talk, please feel free to enter questions in the Q&A, and we will do our best to answer all the questions that come up. So Joel, I'm going to put your slides up and let you tell us all about.
Thank you. Thank you, Dara. Can you guys hear me?
Yep. Oops, sorry.
Okay, I got to see a thumbs up. Well, we are so lucky to have today one of the country's experts on vaccines, Dr. Lindsay Baden, who I will introduce in a moment. But I'm going to, before I hand it off to him and ask him some probing questions, I want to just review the topic of seasonal vaccines, which is on many of your minds, and I've been getting a lot of questions about that. And I want to echo Dara's warm welcome to all of you. I could not be more excited to have you here, and I hope that you will add questions to the chat, which we'll try and get to. And Dr. Baden loves tough questions, so the tougher the better. The vaccine technology actually goes back to vaccinia. Smallpox, it was discovered you could prevent by infecting people with sub-fatal doses of cowpox. And the reason we know that is because milkmaids who were constantly getting exposed to cowpox didn't get smallpox. And that's why they say that people, the beauty of a milkmaid, because she did not have the scarred face of many others who got smallpox. And that technology has been unbelievably effective over time, and it's evolved in many, many ways. And we now have vaccines to many major and important pathogens, both fatal and disabling. And the study, Dr. Baden may want to address it, recently came out in the last couple of years in Nature that looked very rigorously at how many lives have been saved by vaccine technology. And I believe the number was 154 million lives were saved by vaccine. So there's a lot of controversy right now about vaccines, and controversy leads to uncertainty. And we are here over the next hour to hopefully resolve some of that uncertainty. Can you pull up those slides, Dara? So I'm just going to give you a snapshot of the main vaccines this time of year. COVID-19 vaccine or SARS-CoV-2 vaccine, influenza A and influenza B, and a relatively new vaccine on the scene, which is RSV. And I'm going to show you the pattern. And this is data from the CDC, pulled off the CDC website this morning. And for each of those three conditions, it shows the levels of circulating virus in the community. And this is often measured by how much virus is in the wastewater. And this happens to be wastewater analysis around the country. And what you can see is COVID has a couple of peaks over the years, and they're relatively predictable. And while the variants may change, the amount of it, the number of infections is very high. And on the left axis, the higher the number is, the higher the line is, the more of this infection there is in the community. And then this is weekly reporting, the end of week reporting throughout one full cycle of years. And what you can see is that in mid-September, we had another peak of COVID in the United States, and now this week and the last couple of weeks, it's starting to come down again. It's not equally distributed around the country, and Next slide, please. This shows the same data for the last couple of weeks, actually about now almost a month ago, by state. And what you can see is there's quite a bit of variability in which states have the most. That probably reflects both the actual infection in those states, but it also obviously reflects how much reporting there is as well. And Massachusetts, where there's a lot of healthcare providers and a lot of measuring wastewaters, was among the very highest reporting states of active COVID-19 infections. So that's COVID-19. Next slide. Now we're going to look at influenza. And this slide shows influenza A. And what you can see when you're looking at wastewater up until September 20th, 2025, is that there is this very characteristic and very reproducible winter peak. And the peak last year in 2025 looks like it was late January and early February. That peak with vaccination has become lower because more people are vaccinated, and it's also been pushed out farther to the right. So it occurs a little bit later in the year than previous. Every year it's a little bit different. Every year it starts at different times and it peaks at different levels. And there's a lot of different influenzas within this, different types. But that's a general pattern that shows this winter predominance of influenza. And what we know is that vaccines can decrease the complications of influenza. As of a month ago, there were no influenza cases being reported in the wastewater. Dr. Baden may update us whether that's occurring now, but I know in my own practice, I have not yet seen the first case of influenza, but I'm sure it's coming soon. So that's influenza. And the third respiratory virus we think about is RSV, or respiratory syncytial virus. And the reason we think about it is because we now have a vaccine. So we have to think about it. It's primarily an infection that negatively impacts very young children, RSV, or immunocompromised children. But the same is true for older folks, and there are now indications how to use the current RSV vaccine, which I think Dr. Baden will probably talk about. So that's setting the table for our conversation. Again, please enter your questions into the chat. And with that, I would like to warmly welcome my dear friend and dear colleague, Dr. Lindsay Baden. Dr. Baden is the director of the Brigham and Women's Hospital Dana-Farber Infectious Diseases Immunocompromised Host Inpatient and Outpatient Consultative Services, and he serves as the division's director of clinical research at Brigham and Women's Hospital and MGB. Dr. Baden's research interests focus on early-stage vaccine development and the development of novel diagnostic and therapeutics for fungal and viral diseases that affect transplant and cancer patients disproportionately. He is the program director for the clinical research centers of the Harvard Catalyst at Harvard Medical School, and he directs the Translational Accelerator Center for Clinical Investigation at Brigham and Women's Hospital. I will also say that Dr. Baden and I trained together many years ago, and he is one of the nicest and smartest people I know. And whenever I have an infectious disease question or a vaccine question, I go to Dr. Baden. So, Dr. Baden, unmute yourself, and I'm going to now interrogate him, as I always do, in my affectionate way. Tell us, why don't we start out with what is your approach to seasonal vaccines, going through those particular illnesses first?
And I don't know, Dara, if I have a slide showing capability, but given, Joel, your opening remarks, I would like to show 2 slides from a grand rounds I recently gave at UT Southwestern to drive home some of the really important points you've just raised. Let's see. Look at that.
If you go to share, you do have, there you go. Perfect. We see it.
Okay, so 2 slides that I want to share. This slide, and I'll leave it in non-presenter mode, just to really double down, Joel, on your comments. I would argue that the two things that have helped health the most in the last 100 years have been sanitation, hand washing, and vaccines. And this image, which is my opening image of that talk I mentioned, reminds us that polio, for example, FDR, Senator McConnell, recent majority leader, and then my wife's uncle, all suffered from polio. He actually was part of the March of Dimes. But over here, we have remember the iron lung wards, some of which were developed here at Brigham and Women's. And then Mr. Anderson, who was a lawyer who died last year and was on a vent for 60 years. So just reminding us that not seeing something does not mean it does not exist and does not mean it's not a threat. And we shouldn't lose sight of our simple ways to prevent severe illness, to the point where we had that classic Life magazine cover of the iron lung wards. They were real, and they can come back if there's enough transmission in naive individuals. And then your other comment, Joel, which was the Lancet paper from last year, trying to remind us just in numbers. And these are, 2-year-olds who die, are paralyzed, are significant morbidity that they then bear for the rest of their life with a vaccine preventable illness. It's fully reversible and it never happens. And it is very hard to say thank you for a problem I did not have. But I do want to put that plug in that in terms of vaccines, which there's some debate if it was really vaccinia from cows or equipox from horses. But that's for academics. The reality is it was figured out 230 years ago by Jenner, experimenting on his kin, that allowed us to develop a field where I can get an attenuated form of a virus or an antigen. My immune system goes out for a jog. It now becomes activated against that pathogen, and I don't get sick. And we take that for granted because we don't see it. And I think our nation currently is paying the price. We were talking earlier about measles and how there are outbreaks in multiple parts of the country, at least 3 deaths of children in the last few months. So these are very real concerns. The respiratory viruses, which is your question, and I do want to focus in on that because we as a nation have accepted 50,000 deaths a year associated with flu on average for the last decade. COVID has changed things a bit, but we would have on average about 50,000 deaths, often in individuals who are older, who have cardiopulmonary condition, other medical conditions, who can least tolerate an infection, and they succumb to the complications. The easiest way to prevent that, or at least to substantially diminish the morbidity, is through vaccination, and vaccination timed in a way that's related to when these viruses spread. Flu, we're used to with the fall to winter surge. And as you pointed out, Joel, we can detect when it comes to town because it often comes from Southeast Asia to the West Coast, sweeps across the country pretty quickly. And then as it comes into town, immediately spreads in the micro communities to the macro communities that it's introduced to. And those of us who are least able to tolerate it then have severe illness. And so flu has not yet arrived, but it's coming. We know it's coming. COVID is here and in part has been spreading wildly because I think we've let down our guard in terms of how we handle respiratory etiquette and interacting. And then RSV is a little bit different in that it's not as biodiverse and doesn't have quite the same surges, although it's quite a serious issue for older individuals and for neonates, with one of the most common reasons for NICU admissions and prolonged stays, so that it has a substantial morbidity that we need to think about. But vaccination is a very easy way to mitigate many of the complications just mentioned.
Thank you very much. Let's start with influenza. What is your approach? Who should be getting the regular dose? Who should be getting the high dose? When?
So I think that I'll have the simple and then the complicated. I think the simple is we all should be vaccinated. And the most important thing is to be vaccinated. And which flavor of vaccine is second order to being vaccinated? And I hope by now, end of October, all of us on this call and listening in on this call have been vaccinated. I hope everybody around you has been vaccinated. If not, please make that happen. The question of which flavor of vaccine, I think there is the flu mist, which is the live attenuated that goes in the nose, really for kids. Then there are the shots, and the shots are the traditional flu vaccine, which we all have been getting for years. And then the high dose. The high dose is important for older individuals and individuals whose immune systems may be a little slow. And what a slow immune system is complicated because there's so many reasons, from diabetes to renal failure to immunosuppressive medicine to being very old. But different reasons. But it's more important to be vaccinated than to get a high dose. That's the most important.
Thank you very much. And some of my patients will tell me every time I get the flu vaccine, I get the flu, so I'm not going to do it. Is this why wives' tale, or is there any truth behind this?
Wives' tale.
Okay, thank you.
No, I mean
Good.
I
Yeah.
mean, what gets tricky is if there is virus circulating in the community and you get vaccinated, some subset of individuals will have things happen at the same time. But the vaccines that we're talking about are not live attenuated. You cannot get RSV, flu, or COVID from the vaccines that we are using. It is not possible. And so if you happen to get actual infection, it is coincidence. These vaccines cannot give you infection.
Thank you very much. All right, let's move on to the COVID-19 vaccine. And for the audience, I'll just tell you that Dr. Baden was a pioneer in this area. In fact, he was the first author on the first New England Journal article that proved that the COVID vaccines are effective from his own clinical work. But I'm going to ask you to take a step back and first address the question, who should get a COVID vaccine?
So this is the CDC guidance has been fluctuating. The IDSA just came out with its guidance. The AAP, the American Academy of Pediatrics, and the American Academy of Family of OB have come out with their guidances, so that there are different vaccine guidances coming out to be aware of. I think in the pregnant state, it's very important to be immuno-optimized, which is what I think vaccines are, both for mom, because pregnancy is an immunotolerant state by definition, because you have to tolerate the fetus, which is half not you. And then the neonatal state, which is the newborn, is incredibly vulnerable because they have a brand new naive immune system. So the more immunity they can get from mom, the better. So we're not going to dwell on that, but conceptually, it's incredibly important in that arena, which is why the obstetrics community comes out with their annual guidelines and have already come out with guidelines, and they recommend it. There is no known teratogenicity, no known adverse event that is special in that setting. In terms of adults and the COVID vaccine, my own view is we all should get it. Now, there are recommendations, and the recommendations, I think, have some wisdom to it, so it's worth thinking them through. The issue of increased toxicity of the vaccine by different groups, there is none. So now there is the myocarditis in the 20-year-old boys who get vaccines too close together when they were seronaive. So it's hard to know how that plays out today when we're no longer seronaive because we've been vaccinated. We've also had COVID, and there is a longer interval between antigen exposure. But that was, I don't want to diminish side effects. There's allergic reaction there. So there are side effects, but they're very small. The benefits are substantial, as we all remember 5 years ago, in a seronaive population where none of us have been exposed to COVID. Our hospitals were overrun with severe cases, and it was a leading cause of death in this country in 2020 to 2021. That has been ameliorated some because we now have background immunity from vaccine and infection. So that changes our risk profile. But there's still clear evidence of severe morbidity for those who are older. And we need to put a cutoff. And I see in the question, there's a question about what does old mean. And I think
Careful here, careful.
no, for all of us, it's older than I am. But in terms of vaccine and prevention, I think that it's a continuum. It's not a threshold. We need a threshold because we have to make recommendations, but it's not as if you're 50 and all of a sudden you're at risk when 49 you weren't, or you're 60 and you weren't at 59, or you're 70 and not at 69. So it's a continuum. And the older you are, when you're in your 90s, you're much more vulnerable than your 80s or 70s or 60s. And so the question is, what's the risk benefit balance, which is a decision we make in clinic every day. And if the side effect is very small, 1 in 1 million, then what is the benefit in terms of what level of benefit for severe illness, hospitalization, loss of days of work? And so I'm not sure in a 30-year-old marathon runner, the benefit is much smaller than a 60-year-old diabetic controlled with some high blood pressure and a little elevated cholesterol. The benefit is probably significantly higher in the 60-year-old with comorbid illness than the 30-year-old marathoner. There still is benefit in both, just more in one, compared to the risk, which is extremely small, but not zero. And so that's where we all have to wait. It's easier for me because in my practice at Mass General Brigham, at Brigham and Women's, in patients with other illnesses, it's a no-brainer that they all should be vaccinated because they all have some kind of other health condition, which makes the benefit that much higher.
May I ask a question there? I've heard that the getting vaccinated helps reduce the likelihood of developing long COVID after you get sick. Is that true?
So long COVID is a hot topic, and it's a very complicated topic because we don't have a good definition. There are data which suggest that if you've been previously vaccinated, your risk of long COVID is lower. I find those data challenging because people who are vaccinated have different health-seeking behaviors than people who are not. So there are data which suggest that. I think it's very hard to prove that definitively. And as Joel already alluded to, heavily involved in the initial development studies for mRNA 1273, the Moderna vaccine, very analogous to the Pfizer. All my funding was through the NIH, no industry connection other than connected with them because they make the product and we figure out if it works. But the issue of how this impacts long COVID, I think probably prior immunity prior to wild type infection decreases the complications of natural infection, but very hard to prove. But that there are observational data which suggest that.
Okay, thank you.
Thank you. And so now you've convinced us to weigh our risks, talk to our healthcare providers, and get vaccinated. There's more choices this year. We have additional vaccines. Tell us about the COVID vaccines that are available and whether there are, how we should be thinking about it, whether we have a choice, and if we do, does it make a difference?
Yep. So in terms of which vaccine, and many vaccines were developed, there are 3 currently available in the US. 2 are mRNA, 1 by Moderna, 1 by Pfizer, and then the protein, which is by Novavax. And there are different properties of these constructs. And the questions have been raised around durability of the immunity with the mRNA platform versus the protein platform. Unclear what that means because the durability is assessed by titers, and whether titers, the antibody, we vaccinate you, we check your blood level, we see antibody, and if the higher the titer, the more protected we think you are. That's probably true, but the immune system is much more complicated than just circulating antibody. There are T cells and other kinds of immune response which are stimulated with vaccination, which is different than passive immunotherapy, which are the monoclonals. And then the question of which construct is better, the protein versus the mRNA, hard to answer. I think the most important answer is get vaccinated. Now, which one the mRNAs have a lot of favorable properties. I don't really see a difference between Pfizer and Moderna. There is a difference between the lipid delivery system, a slight difference of the immunogen dose in the vaccine. But essentially, I think of them very similar, which is reassuring because all the studies done independently by both companies all show the same kind of results. So I find it confirmatory data by looking at the RCTs and the other studies published. But the mRNA, the big advantage of the mRNA, which has not yet played out, is the speed of manufacturing. So mRNAs is like primers. So if I want primers to make an experiment in the lab, I can say, here are the primers I want, order them, I have them next week, because all I have to know is the nucleotide sequence. Same thing with mRNA. mRNA vaccines can be manufactured in a month or two from when we know the sequence of interest. Protein takes 6 months. So we lock in as a nation in end of first quarter, early second quarter for our vaccine sequence. And this is with flu, but COVID is following that, but it doesn't need to. Therefore, we're locked in on a sequence like the current vaccines are the JN1 sequence, which is an earlier version, while the XFG is what's circulating. The letters don't mean anything. What it means is that over months, COVID is changing and evolving, and so we get new strains and new variants. They're still covered by the vaccine. It's not as if the strain is a totally different genetic, unrelated. It's a descendant of the prior, but it's not as close as we would like it. So currently, I don't have a strong recommendation between protein and mRNA, although the mRNA is more available because manufacturing to scale is a lot easier. In the future, it wouldn't surprise me if mRNA can lag a month or two behind the circulating sequence, while protein is 6 months behind the circulating sequence because of the manufacturing requirements.
So thank you so much. And I'm looking at our questions, which are fantastic coming through, and I encourage you to add more questions. I just want to follow up on that point you made. So for the people who are online here, their doctor has recommended they get the COVID vaccine, but it's up. They haven't decided, or there's no specific recommendation. Would you go with the Novavax or the mRNA, or there's not enough information to
I go with the
different?
I'm a pragmatist. Novavax has been slow to hit the shelves, so I've not been able to get it yet.
Okay.
So, and I don't think it's better. If we only had Novavax, I'd use it in a heartbeat. If we only had mRNA, which is the current situation, I use it in a heartbeat. If we happen to have all of the above, then we can have a discussion. But the reality, in my view, is it's better to be vaccinated than not vaccinated.
Okay.
And we know that COVID is circulating at high levels through wastewater and other kinds of monitoring. So it is in the community. It is around us today.
Great. Thank you so much. And then there's so many questions, so many other areas to go, which we'll get to. But let's go on to the RSV vaccine. You mentioned it's a little different than the first two we talked about. What is your recommendation on the RSV vaccine? Who should be getting it and when?
So I think the current recs, and again, the CDC recs are a little complicated because they've changed in the last 6 months and not driven by hardcore science.
I'm going to get back to that point later, but go ahead.
Yeah, but in looking at the sum total of the recommendations over the last 3 years, because the RSV is easier and harder. A couple of things that make it easier is RSV has been co-circulating with us for decades and decades. So the virus has a certain amount of stability in relation to our immune selective pressure. Because and my wife scolds me about this, but my job is to think like a bug. So if I'm thinking like RSV, I'm trying to spread among people. As I spread among people, you get an immune response. That makes it harder for me to infect. So I have to change a little bit. So the bugs are continually adapting and changing so they can spread between us because that allows, they don't care if we get sick. They just want to spread. So we have RSV A and RSV B. There is a C, but it's really A and B that's the most important for human disease. And it has co-adapted with us for a long time. So it's not changing as much as we sort of see with COVID. And flu is changing because of the animal reservoir. And so there's a lot of zoonotic trafficking between viruses, the avian, the swine, and then eventually jumps to us. And that leads to a different kind of flu incubator than sort of a COVID incubator, which is between us while it's still evolving, and RSV, which is between us, but it's not evolving as much. So that allows the RSV vaccines to be relatively stable. We've only had them 25 years ago is a big problem because the formalin fixed RSV vaccine may have caused some enhancement, but that was a wholesale killed. Now that it is a subunit that is the same fusion, so it's the RSV fusion protein, and actually the RSV biology is what enabled us to make the COVID vaccine, because we could get the trimer fused with a certain way, a cysteine residue that allowed it to stay in the closed state. What I mean is, if you have an umbrella and your umbrella is closed, and that's the way it is most of the time, I need to recognize it closed so I can prevent it from opening. Once it's opened, then it's hard to close it again. And the trimer, the spike, which makes the trimer, is trying to bind to a cell open like an umbrella and inject its material into your cell and take it over. What we were able to do with RSV that we used for COVID and then came back to RSV is keep it in the closed state. So we lock it in the closed state, and the immune system can recognize the closed umbrella. And we make antibodies to the closed umbrella so it never can open when you're exposed to RSV or exposed to COVID, which actually is really cool biologically. And it was demonstrated with COVID. And with RSV, we can do the same thing. There are two vaccines out there, one adjuvanted, one not. But what we saw in the two large phase 3 studies done in the last, 3-4 years, they were published, substantial decrease in people older than 50. And again, the older you are, the greater the benefit. The more tired your immune system is, the greater the benefit. That there is less severe illness, less hospitalization. So when I think of who should get the RSV vaccine, it's similar to the COVID in the sense that I think it's anyone older than 60 or really anyone older than 50. But if you're older than 50 and you have any risk factors, diabetes, inactivity, overweight, things that make it a little harder for you to fight infection, then it's even more reason to be protected. Any underlying heart-lung disease, kidney disease, a liver disease, things, again, that make you more vulnerable. So it is currently the older than 60s across the board, older than 50s with any hint of a medical condition. And there's no downside to being vaccinated. There is a concern of a Guillain-Barré, GBS, which occurred in 1 or 2 in the foundational studies of 30,000 or more people. So it's hard to know if that's above background or not. And it's hard to know if it's actually above the rate associated with natural infection, which is really what the data are coming out, is that there is a background rate associated with natural infection, that there may be some overlap. And we saw this with flu as well, this discussion from the 1977 flu episode. But then there have been many studies that have shown that the flu vaccine is associated with a rate of Guillain-Barré that is lower than the background rate. And that was a 90 million person study from China that looked at that about 8-9 years ago. So very rare, but has to be balanced against what happens with natural infection or wild type infection and what the protections are, which we've been able to define in high quality studies with RSV and severe illness and hospitalization.
Thank you. And just to clarify, Guillain-Barré syndrome, or also known as GBS, is an ascending paralysis. It starts in your feet and it goes up. That is a neurological condition. It's extremely rare, as mentioned, but it can occur after vaccines, but it's incredibly rare, and it can occur in the absence of vaccines as well. All right, and here's a question going back to flu before we move on to the next.
Did you have a question, Dara?
Oh, thanks. A quick one, which is that a lot of people are asking how often they need to get the RSV vaccine.
And we don't know. Currently, it's recommended once, but it wouldn't surprise me if 5+ years from now, we reevaluate that because we do more study. Because once we roll it out, we get to see the durability of the protection. And so currently it's once in our adulthood. However, I, as a betting man, in the next 5 to 10 years, I bet you we're going to say boost, somewhat like our tetanus pertussis vaccine that we recommend every 10 years.
Perfect.
And in follow up to that, there's another question. Are there any people who should get the flu shot twice a year, once in the winter and once again in the spring?
No, but you can always give me a circumstance where if you decided to go to the southern hemisphere in the spring and we're likely to be in a highly flu, because flu has a hemisphere, it's inverted in the different hemispheres. So you can come up with a scenario where somebody is going to a high exposed area, and then I would consider it, but that's the exception. For the flu, the most part is get it in October. Get it right around now because our winter season is coming and we know it's going to be surging imminently.
And I won't ask a show of hands of the audience on who's had it yet, but you should all get it. Last vaccine question, I promise, and then I'm going to get to some other related topics is, do you have recommendations on whether you can get one vaccine at once or two vaccines at once or three, combining them together? Any thoughts on that?
Yeah, and so this is for many of us, we don't like getting stuck. So there are the combined flu RSV vaccines and flu COVID vaccine, with the flu COVID right now being clinically deployed. So it wouldn't surprise me if also in a near term there can be a triple vaccine, and that'll just make life easier. Although the RSV is not that frequent, so that's a little easier. I think the COVID flu, there's no reason not to get them together and be done with it. But some people want to spread them out, and there's nothing wrong with that either. Typically, between non-live, so inert vaccines, we say at least 2 weeks between dosing. So that if I were to get it on October 1st, then I should get the other one after the 14th because of historical sort of sense of spreading out sort of the immune stimulation. So that's sort of what's recommended. I think that getting the combined vaccine is as good as getting two singles.
Okay, thank you so much. All right, I'm going to we'll come back to vaccines if we have time at the end. I think we will because there's a lot of great questions. But I want to change gears slightly. So now you've convinced us. We're all going to go to the CVS and get our vaccines. What else can we do to prevent the spread of seasonal viral infections?
And so I think there are several things we can do, but I also do think a lot about modulating to the level of risk. And what do I mean by that? If I have a 95-year-old at home, I want to be very careful not to bring something home to them because the consequences can be much higher. And so to some degree, the level of vigilance on being careful depends a bit on who we're around. I sort of wear masks, and I will say these masks, these things, if it can work, actually do protect the sender not spraying you and the receiver not getting sprayed. So I actually think that the common sense is if I feel sick, and I was talking again to my wife about the COVID test. My view of it is if I feel like I have a viral syndrome, whether or not my COVID test is positive, I don't think matters. I have a virus. Now, I can put a name on it or not, but if I feel like I have a virus, I probably have a virus, and I probably should not be exposing other people, be it on the subway, the bus, the plane, the mall. So it's the common sense for each of us that if I feel like I have a virus, I should think long and hard about exposing other people. Then separate from that, things that I can do is wearing a mask, particularly when I'm out in public with random folks in very close proximity. I think being outdoors, the volume of distribution is such that the risk is very small. Being indoors, particularly in a closed area with lots of people with so-so ventilation, the risk goes up. Now, it's easy for me to say that. It's very hard to then translate that into how I conduct the rest of my day. And then little kids, particularly little kids at school or daycare, are supposed to go out and get infected because that's their job to learn, including their immune system has to learn. but then what do they bring home? So, Joel, this is not an easy answer. I think it's if you're sick, be thoughtful to others, and you can do things to prevent be the sending team or being the receiving team. And that closed spaces with poor ventilation are higher risk than open spaces with excellent ventilation. And then you need to do the assessment depending on who's at risk. And as I said, I almost always wear a mask because I take care of patients with a weakened immune system. So the last thing I want to do is go into clinic or into the hospital and spread things to other people because it's the least they can tolerate. But it's using that, and I hate the concept of common sense, but it's common sense and understanding risk and how to mitigate the risk where there's the greatest benefit.
Thank you
May
very
I
much.
jump in
Oh.
a little on that? Because we have a lot of patients traveling around the holidays and air travel. What would you say about air travel? A lot of people don't wear masks anymore on airplanes. How can we lower our risk when we're traveling?
That I think is really hard because I mean, I will say the HEPA filters on the planes are pretty good. Now, a lot of planes are being canceled these days, so we have to get over the current flight hiccups that are going on. The question of what to do in the waiting lounge, when you're waiting to get on the plane, when you're shoulder to shoulder to people and they're breathing on you, that's the highest risk. When you're on the airplane, the highest risk is sort of the seat in front of you, seat behind you, and seat to the right and left of you. You're probably less at risk for 10 seats in front of you because the airplane ventilation is pretty good. How to modulate that is really hard because it's hard to sit on a plane for 5 hours with masks on. And we have to sort of balance what can keep my sanity versus what actually is proportionately reasonable. But I have a mask in my pocket. I'm always prepared to put it on. And if someone around me looks sick, I usually do put it on. And the other thing I didn't say is sort of hand washing and sort of the alcohol, because again, you're going to be on the plane, you might eat some food. It's nice to be able to clean your hand in case you touch something that might have had some germs on it. This, Dara, does not, it's not open and shut. It's sort of a sliding scale of common sense in a very dynamic environment of, I want to go see my loved ones, and seeing my loved ones is the whole point of everything we're doing. This is where vaccines really help because you get a vaccine and you're good for the season. So you don't have to remember and you don't have to worry about it, which is why, in my mind, but I'm biased, I'm an ID guy, and I am so glad that I saw measles as a fellow and have not seen it since. I am so sad that I'm likely to see it very soon. And that's because we actually have tools that really work so we don't see things, which is a reflection of the tool working, not that we don't need the tool.
Thank you for that great answer. And I'm just going to add that I encourage all of you to have portable Purell or alcohol sanitizer in your pocket. And at the airport, for example, you're just as likely to get it from a doorknob or a handrail. And just frequently, and especially before you eat any food, to yourself, Purell, and your loved ones and your family, and make sure people wash their hands before they eat. That's an important
I keep a
moment.
mask and a little Purell in my pocket.
Fantastic.
There's no
Good.
reason not to. It costs me nothing, just a little room in my pocket.
Okay, and there is a wonderful mounting group of questions that are going to go, but I'm going to ask you before I do one other general question. You alluded to this already, but there's a lot of politics around vaccination right now, and where can people find trustable information? What do you recommend
Um,
for that?
it's hard. In that there have been the CDC has been so reliable for our lifetime that the current way in which data are analyzed and shared has sowed more distrust, which doesn't help any of us. But what has happened, and as we speak of conflict, so I'm involved in the IDSA guidelines for vaccines. So the IDSA came out with guidelines last week for COVID, and we're coming out with RSV and flu very soon, where learned societies are getting our experts together to synthesize the latest information to make sure that the guidelines we have are as thoughtful as possible, given the complexity of the data around us. I also know that there are regional consortia, such as most of the New England and northeastern states have come together to make recommendations. And in Massachusetts, our Robbie Goldstein, our public health commissioner, has lowered the activation energy to be able to get COVID vaccine by writing us all a prescription so we can go get it if we think we need it. So different states are doing different things, while some other states are discouraging vaccination, even the routine childhood vaccination. So there's a lot of different information out there. I think that our learned societies and many of our thoughtful state public health departments are trying to give us thoughtful guidance, but then it gets confusing because there's no one easy source. And I wish there were an easier answer, but it gets difficult when the federal source of this has become more uneven in how they evaluate the data and communicate.
Thank you very much. We have about 10 minutes left. Dara, can you just go through the online questions and see if there's any that haven't been answered?
Yes, thanks. I answered a couple just that were about shingles and pneumonia because I didn't think we'd get to them. One question is, does the vaccine actually prevent you from getting COVID? And if not, what does it do?
So it's become more difficult and so I will confess that I feel guilty. I feel guilty because the definition for vaccine efficacy that we created 5 years ago, I contributed to because we had to work with the FDA when COVID was emerging and what was the study outcome that would be convincing that the vaccine worked. And the definition that we came up with the FDA with these constructs that did not exist yet was avoidance of molecularly confirmed symptomatic illness. And that was a research definition that we needed to demonstrate that if you had a cold, we tested you for COVID. If you were vaccinated, you were less likely to have COVID than if you weren't. And there was a 95% protection of not getting COVID. Once we've all gotten COVID and we all have hybrid immunity, it becomes much more difficult to establish, did it actually prevent you getting COVID, particularly when there's a whole lot of asymptomatic or truly minimally symptomatic infection. But I would view clinically, with my clinical hat on, if you don't get sick and go to the hospital, the vaccine worked. That's what I care about. I care about hospitalization and severe illness. And there we know that those who are vaccinated are hospitalized for COVID substantially less than those who are not. Whether or not there's asymptomatic acquisition becomes impossible to prove because there is no way to do those systematic studies. And so to me, vaccine failure, in my view, is not getting COVID. Vaccine failures, you get hospitalized with COVID. You get sick. And that we know it protects against. Very hard to prove who does or doesn't get COVID because most of it now is asymptomatic or minimally symptomatic, which to me is success. Guess what? Prior to COVID 6 years ago, there were 4 coronaviruses that we all got and never cared about. Can there now be a 5th coronavirus that we all get and don't care about because we no longer get sick from it? So I would argue, in my view, that not getting sick, meaning hospitalization, severe illness, is a smashing success. And that is evidenced by the decrease in hospitalization by vaccinated individuals compared to unvaccinated individuals today associated with acute COVID infection.
Oh, I'm sorry.
No, please. I was just going to say that in the chat, there are people asking, if I had 4 vaccines in the first X years and then I still got COVID, but this, here you are alive to ask the question. You're saying that was a success. That doesn't mean your immune system failed to respond to the vaccine. It means that it probably made
it worked.
Right.
It worked. And that's why I say I feel guilty, because if I get COVID, that means the vaccine failed. That was a research definition for licensure, which we needed when we had no idea what would be an appropriate bar to say this works. What I care about as a clinician is you don't get sick. That's what I care about. I actually don't care if you get COVID because guess what? You got 4 other coronaviruses last year and didn't know about it, and we didn't test for it, and nobody cared. So we want to make SARS-CoV-2, or a coronavirus number 5 that we don't care about because we get it and we don't get sick. And that is where prior immunity makes a big difference. And the issue of vaccination is boosting that prior immunity. So for the next several months, I'm less likely to get sick because my immune system can easily handle the acute infection and turn it into a nuisance and nothing more.
Do you have any recommendation on whether patients should have home test kits? And if so, should they do the COVID test kits, the flu test kits, the 3-in-1 test kits?
Yeah, that it gets tricky. One is the quality of the test kit, and its detection of the circulating virus. The other is what are the treatments? And
Mhm.
right now with RSV, we don't have a tablet. We do have a tablet for flu and we have a tablet for COVID. In terms of neuraminidase inhibitors, Tamiflu, oseltamivir for the flu side of the house, Paxlovid, nirmatrelvir, ritonavir for the COVID side of the house. In that there, I think of it for why would I do testing? I'd do testing if I want to know because I need to isolate you for some reason. You work in a nursing home. You have someone at home who's getting chemotherapy or had an organ transplant. If I know that you have it, we might handle you a little different. The other is if I know you have it, I might treat you because you have advanced HIV and your CD4 count is 20. You're on Rituxan for the anti-CD20, the medicine for autoimmune disease or lymphoma. So if you have a reason why I'm worried you're going to get more severely ill, then I'd want to diagnose it so I can give you the medicine, be it oseltamivir or Paxlovid. The issue of which one to test, testing for flu today makes no sense because there's no flu in Boston. A month from now, testing for flu may not be necessary because everybody has it. So this is where we have to use clinical judgment in that what is circulating, what do I likely think you have based on your symptoms, and would I do something different if I knew the name of the virus? And I frame it that way because life is complicated, so it's hard to answer the question. But I think that if there's a reason why I might want to treat you, then I'd want to test you to put a name on it.
And let me just add that I think there's another subtle twist on that is if you're going to be seeking medical care and you're going to be going to the hospital or you're going to be going to visit relatives, some of whom may be sick, it's nice to know that you have COVID so you don't spread it to other people. So I agree with everything Lindsay said, but I would keep a test kit home for the three, flu A, flu B, and COVID. And if you feel like you're sick, in my opinion, so not that you're necessarily going to get treated, but so you're not inadvertently passing it on to other people, I don't think it's unreasonable to
I
test
agree,
yourself.
Joel, but I'm going to take it one step further. If I feel like I have a cold, I test for flu and COVID and they're negative. Does that mean I don't have a virus that I can't give you? If you feel like you have a cold, please work hard not to give it to your neighbor. Whether it's on the airplane, in the movie theater, out to dinner, in the mall, or the family you're visiting, assuming you love that side of the family.
Right, right. You can go either way.
So I think you should test because it's good to know. But just because I don't have COVID or flu, if I feel like I have a virus, I probably have a virus.
Hmm.
I just may not be able to name it because there are 100 others we don't test for, like
Beautiful.
adenovirus and rhinovirus. I mean, there's echovirus, enterovirus, all sorts of things. And it's how just to think about not infecting other people.
Beautiful. Thank you so much. Dara, any other questions online? If not, I have a couple more to throw.
Well, I guess the question is, should we open the little Pandora's box of measles, or if you want to just in the remaining 4 minutes use your.
Yeah, there was a question I saw about measles, and let me throw that at you because I'm getting a lot of that from my patients. Is the typical story is someone born in that window, 1959, 58, 59, 60, 67, where there was a vaccine, but it wasn't a very effective vaccine. And so people in that window period may not have had native immunity. And there's, do you have any thoughts on how to manage those folks?
A couple of thoughts. One is if you're born for 1957, you're protected against measles. Why? Because everybody got it. It is the most contagious person-to-person virus, period. 20 to 1. Dara and I were talking earlier. The R naught is 20 to 1. If I have it, I infect 20 other people, assuming they're not immune. It is a super spreader. In fact, that's what we're witnessing across this nation currently, which is in places where vaccines have been pulled back a little bit, measles has quickly moved in and spread like wildfire. So I think it's a very serious virus. 2 to 5 out of 100 get pneumonia. 1 out of 1,000 has CNS disease, encephalitis, die. This is a very serious. And one of my other hats is I edit for the New England Journal of Medicine. So we had an emergency review article on measles that we published about 3 months ago because I knew. So there's a nice review article stating the latest on it because in my view, this is coming for all of us because it spreads. And if we don't keep vaccination 95%, it is spreading to all of our communities and we're witnessing it. What to do with the 63 to 67 crowd who had the inactivated vaccine that doesn't have the same durability? What I would say is everyone should have gotten a second dose. So they should have been at least 1, if not 2 MMRs subsequently with the current vaccine formulation. Hopefully we got them in college, if not later in life. But, Dara, we were talking about testing and then boosting. There are lots of ways to do this, but every time we bring in 4 steps in the process, it's asking for us to make a mistake. The downside of the MMR vaccine is trivial if you have a normal immune system. If you have a weakened immune system, it's a different discussion, but there it may be more important because you're more vulnerable if you're not immune. But to your question, Joel, in the pre-67 unvaccinated or inactivated vaccine, the Schwartz strain, you should definitely get an MMR as an adult. The other thing about the MMR, particularly in young women, is the R rubella, to make sure there's immunity to prevent any teratogenicity, because rubella infection in pregnancy, it's a teratogen, and that is something we just want to prevent. So the MMR vaccine has many, many benefits. But I would say anyone before 67 should have gotten at least 1, if not 2 boosters since then.
Perfect. I know that both of you have other engagements at 3:30, so I'm going to wrap us up. But so in a nutshell, born between 1959 and 1967, get another booster for MMR. Okay.
Yes.
Wow. All right. We covered so much today. We covered COVID, RSV, we covered flu, we covered strains, vaccines, prevention, transmission. And at the end of it, my goodness, my head's spinning. But the good news is we're going to tape this webinar. We're going to post it on our website. So if people want to hear it in slower motion, it will be there for you. So thank you, both of you. That was awesome, informative, life-saving. And I want to thank the audience for your excellent questions and engagement. And I hope to see you all in November. Our next webinar will be Dr. Single and O'Donnell talking about early detection of cancer. So thank you all. Have a safe and healthy fall and winter.
Be well.
Thank you.